The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series, Volume 45, Lesson 18. Testosterone Therapy. Is it safe? A case-based approach. Now in its 45th installment, the AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. For more information or to subscribe to the AUA Update Series, please visit the AUA University.
AUA Update Series, Volume 45, Lesson 18. Testosterone Therapy. Is it safe? A case-based approach. Authors Gail Safadi, MD, David Hinojosa Gonzalez, MD, and Mohit Khera, MD, MBA, MPH. Introduction. Low testosterone affects up to 26% of males aged 40 to 70 in the U.S., with its prevalence increasing with age and testosterone deficiency, which incorporates symptoms along with a low testosterone level, has a prevalence of around 6% to 12%. The management of low testosterone has evolved significantly over the past decades, with new evidence emerging, particularly regarding its cardiovascular safety. Historically, testosterone therapy safety has been shaped by conflicting observational studies, regulatory warnings, and most recently, landmark randomized controlled trial data. The 2018 AUA Guidelines on Testosterone Deficiency established evidence-based recommendations for diagnosis and treatment, emphasizing the importance of cardiovascular risk assessment. However, the completion of the TRAVERSE trial in 2022 has provided new insights that require integration into clinical practice. Testosterone therapy offers several well-established benefits for men with confirmed testosterone deficiency. According to the AUA guidelines, testosterone therapy has been shown to improve sexual function, including libido and erectile function, enhance mood and sense of well-being, increase bone mineral density, and improve body composition by increasing lean muscle mass and reducing fat mass. Additionally, some men experience improvements in energy levels and cognitive function. However, testosterone therapy is also associated with adverse effects that require monitoring and management. Polycythemia, characterized by elevated hematocrit levels, is one of the most common adverse effects and may necessitate dose adjustment or temporary discontinuation of therapy. Gynecomastia and breast tenderness can occur due to aromatization of testosterone to estradiol. Other potential adverse effects include acne, oily skin, testicular atrophy, reduced fertility due to suppression of spermatogenesis, and exacerbation of sleep apnea in susceptible individuals. This case-based lesson addresses contemporary safety controversies in testosterone therapy, providing practicing urologists with evidence-based guidance for risk assessment and patient counseling. Brief overview of modes of testosterone therapy. Testosterone gel. Topical testosterone gels are among one of the most commonly prescribed modalities for testosterone therapy due to their ease of use, flexible dosing, and favorable pharmacokinetic profile. These gels allow for daily application and provide relatively stable serum testosterone levels without the peaks and troughs associated with injectable formulations. According to the AUA guidelines, testosterone gels are particularly advantageous for patients who prefer non-invasive treatment and require fine-tuning of dosage based on symptom response and serum levels. Despite these benefits, testosterone gels carry specific safety concerns, most notably the risk of secondary exposure, transference. The U.S. Food and Drug Administration, FDA, has issued a boxed warning for testosterone gels due to reports of virilization in children who were inadvertently exposed through skin contact with treated individuals. To mitigate this risk, patients are advised to apply the gel only to clean, dry, and intact skin of the shoulders or upper arms, allow it to dry completely, and cover the application site with clothing. While clothing provides substantial protection against testosterone transference, clinicians should counsel patients that gel can penetrate through certain fabrics under specific conditions, particularly with prolonged contact or occlusive clothing materials. Additionally, they must wash their hands thoroughly after application and wash the application site before any anticipated skin-to-skin contact with others. Testosterone intramuscular injection. Intramuscular testosterone injections remain as one of the pillars of testosterone therapy due to their cost-effectiveness and reliable bioavailability. Commonly used esters include testosterone cypionate, testosterone enanthate, and testosterone undecanoate, each differing in pharmacokinetics and dosing intervals. Testosterone cypionate and enanthate are typically administered 100 to 200 milligrams every 1 to 2 weeks, while testosterone undecanoate allows for extended dosing intervals of 10 to 12 weeks with 750 milligrams initially, followed by a second 750 milligram dose at 4 weeks, then 750 milligrams every 10 to 12 weeks for maintenance, offering convenience for long-term management of testosterone deficiency. Despite their efficacy, intramuscular testosterone injections have some drawbacks. One of the primary concerns is the potential for supraphysiologic peak levels, especially with shorter-acting esters like enanthate and cypionate. These peaks can lead to symptomatic fluctuations such as mood swings, acne, and peaks in libido. Additionally, injection site reactions, including pain and inflammation, are relatively common. Proper injection technique and rotation of sites are essential to minimize these adverse effects. Long-acting formulations like testosterone undecanoate have shown more stable serum testosterone levels and fewer fluctuations, which may improve patient adherence and satisfaction. Testosterone pellet. Subcutaneous testosterone pellets are a long-acting option for testosterone therapy, offering sustained hormone delivery over a period typically ranging from 3 to 6 months. These pellets are implanted beneath the skin through a minor surgical procedure, usually in the gluteal region or lower abdomen. Once implanted, they release testosterone gradually, maintaining relatively stable serum levels without the need for daily administration. This makes them particularly appealing for patients seeking a low-maintenance option with consistent pharmacokinetics. Clinical studies have demonstrated that, when using 12 testosterone pellets, serum testosterone levels remain above therapeutic thresholds for up to 113 days post-implantation, with improvements noted in symptoms such as erectile dysfunction, mood, and energy levels. However, testosterone pellet insertion carries potential complications, including pellet extrusion, infection, and local inflammatory responses. Factors influencing extrusion and infection include the number of pellets implanted, body composition, and provider technique. Additionally, inflammatory responses post-insertion may lead to discomfort and scar tissue formation, which can affect hormone absorption and patient satisfaction. Innovations such as incorporating low-dose triamcinolone into pellet formulations have been explored to mitigate these inflammatory effects, showing promise in reducing post-procedural complications. Alternative therapies. Human chorionic gonadotropin. Human chorionic gonadotropin, HCG, is a glycoprotein hormone that mimics the action of luteinizing hormone, stimulating Leydig cells in the testes to produce endogenous testosterone. This mechanism preserves testicular function and spermatogenesis, making HCG particularly suitable for younger men who wish to maintain fertility while addressing symptoms of testosterone deficiency. Typical dosing ranges from 1,500 to 3,000 IU, administered 2 to 3 times per week, although individualized regimens may vary based on patient response and serum hormone levels. Recent studies have demonstrated that HCG monotherapy can improve hypogonadal symptoms even in men with serum testosterone levels above the traditional treatment threshold of 300 nanograms per deciliter. In a retrospective review, patients treated with HCG reported improvements in erectile dysfunction, libido, and energy levels, with no significant adverse cardiovascular events observed. However, clinicians should recognize that men with severe testicular atrophy and significantly diminished testicular volume may have insufficient Leydig cell mass to respond adequately to HCG stimulation. In such cases, HCG therapy may fail to achieve eugonadal testosterone levels despite appropriate dosing, and these patients may require traditional testosterone replacement therapy to adequately address their hypogonadal symptoms. These findings support HCG as a viable alternative to testosterone therapy, especially in men with fertility concerns, or those with borderline testosterone levels in the 250 to 350 nanograms per deciliter range who experience hypogonadal symptoms despite having testosterone levels near or slightly above the traditional treatment threshold of 300 nanograms per deciliter. Selective estrogen receptor modulators. Selective estrogen receptor modulators, such as clomiphene citrate and enclomiphene, are off-label options for stimulating endogenous testosterone production. These agents act by blocking estrogen receptors in the hypothalamus, disrupting the negative feedback loop, and increasing gonadotropin-releasing hormone secretion. This leads to elevated levels of luteinizing hormone and follicle-stimulating hormone, which in turn stimulate the testes to produce testosterone. Selective estrogen receptor modulators are particularly useful in men with secondary testosterone deficiency and preserved fertility goals. Clomiphene citrate is a racemic mixture containing both enclomiphene, active isomer, and zuclomiphene, inactive isomer, the latter of which may contribute to estrogenic side effects such as mood swings and gynecomastia. Enclomiphene, a purified form of the active isomer, offers a more targeted approach with fewer side effects, shorter half-life, and more stable testosterone levels. Studies suggest that selective estrogen receptor modulators effectively raise testosterone without suppressing spermatogenesis, making it a preferred option for men seeking fertility-preserving alternatives to testosterone therapy. Aromatase inhibitors. Aromatase inhibitors function by inhibiting the aromatase enzyme responsible for converting testosterone into estradiol. This reduction in estradiol levels can lead to a compensatory increase in endogenous testosterone production. Aromatase inhibitors are typically reserved for men with elevated estradiol levels concurrent with testosterone deficiency, particularly when symptoms such as gynecomastia are present. Anastrozole is the most commonly used aromatase inhibitor in clinical practice due to its favorable safety profile and ease of dosing. While aromatase inhibitors can be effective in managing estradiol-related symptoms, their use must be carefully monitored. Excessive suppression of estrogen can negatively impact bone mineral density, libido, and overall well-being. A study evaluating anastrozole in men on testosterone therapy found significant reductions in estradiol levels without compromising testosterone concentrations, but no predictors of response were identified. Therefore, aromatase inhibitors should be used judiciously and tailored to individual patient profiles. Testosterone cardiovascular safety concerns. History of controversy. Landmark evidence review. The cardiovascular safety of testosterone therapy has been one of the most controversial issues in men's health over the past decade. This controversy arose despite testosterone's historical use as a therapeutic agent for cardiovascular conditions in the early to mid-20th century, when physicians reported improvements in exercise tolerance and cardiac function in patients with angina pectoris and other cardiovascular disorders. The modern controversy began in 2010 when several widely publicized studies suggested potential cardiovascular risks with testosterone therapy, triggering unprecedented scrutiny from regulatory bodies and the medical community. However, the resolution of this controversy has emerged through recent rigorous clinical research, with landmark trials providing compelling evidence regarding testosterone therapy's cardiovascular safety profile. Heart attack. Initial concerns regarding myocardial infarction risk emerged from retrospective cohort studies suggesting increased cardiovascular events in testosterone-treated men. Vigan et al. Study reported a 29% increase in adverse cardiovascular outcomes among veterans receiving testosterone therapy. However, subsequent reanalysis questioned these findings due to methodological limitations and outcome misclassification. Large observational studies demonstrated cardiovascular benefits or neutral effects of testosterone therapy. Sharma et al. Study analyzed over 83,000 men and found reduced all-cause mortality in testosterone-treated patients. Stroke. Stroke risk assessment has been similarly complicated by conflicting observational data. Early studies suggested increased stroke risk in older men receiving testosterone therapy, particularly within the first 90 days of treatment initiation. However, these findings were not consistently replicated in subsequent analyses, and potential confounding factors limited interpretation. The heterogeneity of study populations, treatment modalities, and outcome definitions contributed to ongoing uncertainty regarding stroke risk. This variability highlighted the need for prospective randomized trial data to definitively assess cardiovascular safety. Sudden death. Reports of sudden cardiac death in testosterone-treated men generated significant regulatory attention, leading to FDA safety communications beginning in 2014. However, establishing causality proved challenging given the baseline cardiovascular risk profile of men with testosterone deficiency and the relatively low incidence of sudden death events. A recent meta-analysis of available data failed to demonstrate consistent associations between testosterone therapy and sudden death. The limitation of observational studies in establishing causal relationships became increasingly apparent, emphasizing the need for controlled trial evidence. Traverse trial. Trial origination and FDA recommendation. The Traverse trial, testosterone replacement therapy for assessment of long-term vascular events and efficacy response in hypogonadal men, was initiated in response to FDA requirements for cardiovascular safety assessment. Following review of conflicting observational data, the FDA mandated a large-scale randomized controlled trial to definitively evaluate the cardiovascular safety of testosterone therapy. The trial design reflected regulatory concerns while maintaining clinical relevance. Traverse enrolled men aged 45 to 80 years with confirmed testosterone deficiency and with a history of cardiovascular disease or cardiac risk factors, representing the population of greatest safety concern. The primary endpoint focused on major adverse cardiovascular events, including non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. Traverse trial findings and insights. The Traverse trial randomized 5,246 men with testosterone deficiency and increased cardiovascular risk, defined as either pre-existing cardiovascular disease, including coronary artery disease, peripheral arterial disease, cerebrovascular disease, or carotid artery disease, or the presence of multiple cardiovascular risk factors, such as diabetes mellitus, metabolic syndrome, dyslipidemia, hypertension, or obesity, representing the population of greatest safety concern to receive testosterone gel or placebo, with a median follow-up of 33 months. The results provided the highest level of evidence regarding the cardiovascular safety of testosterone therapy. Heart attack. The trial demonstrated non-inferiority of testosterone therapy regarding myocardial infarction risk. The primary major adverse cardiovascular events endpoint occurred in 7% of testosterone-treated men versus 7.3% of placebo-treated men. Hazard ratio 0.96, 95% of CI 0.78 to 1.17. Specifically, non-fatal myocardial infarction rates were comparable between groups, 2.1% versus 2.3% respectively. These findings directly contradicted early observational studies suggesting increased myocardial infarction risk with testosterone therapy. The rigorous randomized design and adequate statistical power provided definitive evidence of cardiovascular safety in the studied population. Stroke. Stroke rates in Traverse were similarly reassuring, with non-fatal stroke occurring in 0.9% of testosterone-treated men versus 1.1% of placebo-treated men. The confidence intervals excluded clinically meaningful increases in stroke risk, addressing previous observational study concerns. The trial's stroke findings were particularly important given the vulnerable population studied, as enrolled men had established cardiovascular risk factors, including diabetes, metabolic syndrome, or known coronary artery disease. While venous thromboembolism overall showed no significant difference between groups as a pre-specified endpoint, there was a notable numerical difference in pulmonary embolism specifically, occurring in 0.9% of testosterone-treated men compared to 0.5% of placebo-treated men. This finding warrants attention and continued monitoring in clinical practice, even though it did not reach statistical significance in the trial. Sudden death. Cardiovascular death, including sudden cardiac death, occurred in 0.9% of testosterone-treated men versus 1.1% of placebo-treated men. These rates were not statistically different and provided reassurance regarding the most concerning safety signal from previous observational studies. The Traverse trial's comprehensive cardiovascular monitoring and adjudication process ensured accurate outcome classification, addressing methodological limitations of earlier observational studies. Traverse study applicability and limitations. While Traverse provided crucial safety data, several limitations must be considered when applying results to clinical practice. The study population was limited to men with elevated cardiovascular risk, potentially limiting generalizability to lower-risk populations. Additionally, the median follow-up of 33 months may not capture long-term cardiovascular effects. The trial excluded men with recent cardiovascular events within 6 months, limiting applicability to this high-risk population. Furthermore, only testosterone gel was studied, raising questions about the safety of other testosterone formulations. Beyond the primary cardiovascular endpoints, Traverse identified other safety signals that warrant clinical attention. Atrial fibrillation occurred more frequently in testosterone-treated men compared to placebo-treated men, with rates of 3.5% versus 2.4% respectively. While the absolute difference was modest, this finding suggests the need for awareness and monitoring for arrhythmias in men receiving testosterone therapy, particularly those with pre-existing cardiac risk factors. Additionally, acute kidney injury was observed at higher rates in the testosterone group compared to placebo, occurring in 2.3% versus 1.5% of participants. The mechanisms underlying these findings require further investigation, but they may relate to effects of fluid retention, hematocrit elevation, or other physiologic changes associated with testosterone therapy. Despite these limitations, Traverse represents the most robust cardiovascular safety data available for testosterone therapy and has significantly influenced clinical practice guidelines and regulatory perspectives. Clinical cases. Case 1. Patient with severe cardiovascular risk factors who desires testosterone therapy. Case presentation. A 68-year-old male presents with symptoms of fatigue, decreased libido, and erectile dysfunction. His medical history includes type 2 diabetes mellitus, coronary artery disease with prior myocardial infarction 18 months ago, and hypertension. Current medications include metformin, atorvastatin, metoprolol, and lisinopril. Laboratory evaluation reveals total testosterone of 210 nanograms per deciliter, confirmed on repeat testing, and luteinizing hormone of 8.2 micro-IUs per milliliter. Physical examination. Vital signs are stable, with blood pressure of 138 over 82 millimeters per mercury. BMI is 32 kilograms per meter squared. Cardiovascular examination reveals a regular rhythm without murmurs. Genitourinary examination demonstrates normal external genitalia with bilateral testicles of 15 milliliters volume. Counseling and risk assessment. This patient represents the population studied in the Traverse trial, men with confirmed testosterone deficiency and elevated cardiovascular risk. The counseling discussion should emphasize both the potential benefits of testosterone therapy for symptomatic testosterone deficiency and the cardiovascular safety data from Traverse. A systematic approach to patient counseling can be facilitated by using a testosterone therapy checklist, which ensures comprehensive evaluation and documentation of key elements, including cardiovascular risk assessment, discussion of treatment alternatives, monitoring plans, and patient education regarding potential adverse effects. Such checklists, which have been advocated by professional organizations, help standardize care and ensure that critical elements, such as cardiovascular risk discussion, are consistently addressed with all patients considering testosterone therapy. Key counseling points include confirmation of testosterone deficiency diagnosis based on symptoms and biochemical evidence, discussion of Traverse trial findings showing cardiovascular safety in similar patients, review of alternative treatment options and their relative risks and benefits, importance of continued cardiovascular risk factor optimization, need for ongoing monitoring and follow-up. Treatment plan. Following shared decision-making, the patient elected to proceed with testosterone therapy. Testosterone gel 1.62% was initiated at 40.5 milligrams daily, with instructions for proper application technique and transfer precautions. Cardiovascular risk factor optimization was emphasized, including diabetes management, blood pressure control, and continued statin therapy. Monitoring and follow-up. Follow-up was scheduled at 4 weeks with repeat testosterone levels and symptom assessment. Cardiovascular monitoring included continuation of existing cardiology care and emphasis on lifestyle modifications. The patient was counseled on symptoms requiring urgent evaluation, including chest pain, shortness of breath, or neurological symptoms. Outcome. At 6-month follow-up, the patient reported significant improvement in fatigue and libido. Testosterone levels increased to 520 nanograms per deciliter, and no cardiovascular events occurred. Continued monitoring and risk factor optimization remain priorities for ongoing care. Case 2. Patient with a history of recent stroke who desires testosterone therapy. Case presentation. A 58-year-old male presents 4 months after an ischemic stroke with residual mild left-sided weakness. He reports symptoms of decreased energy, mood changes, and sexual dysfunction that he attributes to testosterone deficiency. His medical history includes hypertension, hyperlipidemia, and tobacco use. Quit after stroke. Current medications include aspirin, clopidogrel, atorvastatin, and amlodipine. Laboratory results. Total testosterone is 180 nanograms per deciliter, confirmed on repeat. Luteinizing hormone is 6.8 micro-IUs per milliliter, and the complete metabolic panel is normal. Hemoglobin A1C is 6.2%. Physical examination. Blood pressure is 142 over 86 millimeters of mercury. Neurological examination reveals mild left-sided weakness consistent with stroke history. Genitourinary examination is normal. Counseling and risk assessment. This case illustrates the complexities and contradictions inherent in managing testosterone therapy in patients with recent cardiovascular events. The Traverse trial excluded men with cardiovascular events within 6 months, leaving clinicians without high-quality evidence to guide decision-making in this population. However, the current expert opinion-based recommendation to defer testosterone therapy warrants critical examination. If low testosterone is indeed a risk factor for cardiovascular events, as stated in the AUA guidelines, then the practice of withholding treatment from men who have just experienced a cardiovascular event may paradoxically perpetuate their cardiovascular risk. The theoretical concerns about initiating testosterone therapy shortly after a cardiovascular event include potential prothrombotic effects, hemodynamic changes, and polycythemia development. However, these concerns must be weighed against the established cardiovascular risks associated with persistent testosterone deficiency, including adverse effects on body composition, insulin resistance, lipid profiles, and endothelial function. In some clinical scenarios, earlier initiation of testosterone therapy might be justified despite recent cardiovascular events. Men with severely low testosterone levels in the castrate range, less than 150 nanograms per deciliter, may warrant earlier consideration of therapy given the magnitude of hormonal deficiency. Similarly, patients experiencing significant psychiatric symptoms, including depression or suicidality, where hypogonadal symptoms may be contributing to clinical deterioration, might benefit from a more individualized approach rather than adherence to arbitrary time-based restrictions. Key counseling considerations include the lack of safety data in patients with recent stroke, the need to distinguish between stroke-related symptoms and those attributable to testosterone deficiency, the importance of comprehensive stroke risk factor optimization, the potential benefits and theoretical risks of testosterone therapy in this setting, and the option of individualized decision-making based on severity of testosterone deficiency and overall clinical context. Treatment plan. In this case, given that the stroke occurred only 4 months prior, and the patient's testosterone level was 180 nanograms per deciliter rather than in the severely deficient range, testosterone therapy initiation was deferred to allow for further cardiovascular stabilization and stroke recovery. However, the decision-making process emphasized shared decision-making and individualized risk-benefit assessment rather than rigid adherence to arbitrary waiting periods. The patient was counseled that the 6-month time frame used in Traverse exclusion criteria represents expert consensus rather than evidence-based practice, and that earlier initiation could be reconsidered if his clinical situation changed or if his testosterone levels declined further. Lifestyle modifications were emphasized, including exercise, stress management, and continued smoking cessation. Neurological and cardiovascular follow-up was prioritized to ensure optimal stroke recovery and risk factor management. Alternative management. A trial of phosphodiesterase 5 inhibitor therapy was initiated for erectile dysfunction, with careful monitoring given the cardiovascular history. Depression screening was performed, and psychological support was offered for stroke recovery and symptom management. Follow-up plan. Reevaluation for testosterone therapy was scheduled at 6 months post-stroke, allowing for further recovery and cardiovascular stabilization. Continued monitoring of testosterone levels and symptoms was planned to reassess treatment candidacy. Outcome. At 6-month follow-up, the patient's neurological function had improved significantly. Testosterone levels remained low at 190 nanograms per deciliter, and symptoms persisted despite optimization of other factors. After extensive counseling regarding limited safety data, the patient elected to initiate testosterone therapy with close cardiovascular monitoring. Case 3. Patient who has a heart attack while on testosterone therapy. Case presentation. A 62-year-old male presents to the emergency department with acute chest pain. He has been receiving testosterone cypionate injections of 200 milligrams every 2 weeks for the past 8 months for symptomatic testosterone deficiency. His medical history includes hypertension and hyperlipidemia. Electrocardiogram reveals ST elevation myocardial infarction, and he undergoes successful percutaneous coronary intervention. Acute management. Standard acute coronary syndrome protocols were followed, including dual antiplatelet therapy, beta blocker, and high-intensity statin therapy. The patient underwent cardiac catheterization with placement of a drug-eluting stent in the left anterior descending artery. Testosterone therapy considerations. The occurrence of myocardial infarction during testosterone therapy raises important questions about treatment continuation. However, establishing causality is challenging given the patient's baseline cardiovascular risk factors and the overall safety profile demonstrated in Traverse. Key considerations include review of baseline cardiovascular risk factors present before testosterone initiation, assessment of treatment compliance and monitoring, evaluation of other potential contributing factors, discussion of Traverse trial findings regarding cardiovascular safety, consideration of testosterone therapy continuation versus discontinuation, counseling and decision-making. The patient and family were counseled regarding the myocardial infarction and its relationship to testosterone therapy. The discussion emphasized that 1. Myocardial infarction can occur independently of testosterone therapy. 2. Traverse trial data suggests cardiovascular safety in similar patients. 3. Individual risk-benefit assessment is required. 4. Cardiovascular risk factor optimization is paramount. And 5. Shared decision-making regarding treatment continuation is appropriate. Treatment plan. Following multidisciplinary discussion involving cardiology, endocrinology, and urology, the decision was made to temporarily discontinue testosterone therapy during the acute recovery phase. Cardiovascular risk factor optimization was prioritized, including lifestyle modifications, medication compliance, and cardiac rehabilitation. Long-term management. At 6-month follow-up, the patient had recovered well from his myocardial infarction with good functional capacity. Testosterone levels had decreased to 220 nanograms per deciliter, and symptoms of testosterone deficiency had recurred. After extensive counseling regarding cardiovascular risks and benefits, the patient elected to resume testosterone therapy with enhanced cardiovascular monitoring. Outcome. Testosterone therapy was resumed with testosterone gel 1.62% at a lower initial dose of 20.25 milligrams daily. Close collaboration with cardiology was maintained, and the patient continued dual antiplatelet therapy, beta blocker, and high-intensity statin therapy. At the 6-month follow-up, no additional cardiovascular events had occurred, and the patient reported symptom improvement. Conclusion. The cardiovascular safety of testosterone therapy has evolved from controversy to evidence-based practice through the completion of the Traverse trial. This landmark study provides the highest level of evidence regarding the cardiovascular safety in men with testosterone deficiency and elevated cardiovascular risk, directly addressing previous regulatory concerns. For practicing urologists, the Traverse findings support testosterone therapy as a safe and effective treatment for symptomatic testosterone deficiency when appropriately prescribed and monitored. The trial's results demonstrate non-inferiority regarding major adverse cardiovascular events, including myocardial infarction, stroke, and cardiovascular death. However, clinical application of these findings requires careful consideration of individual patient factors, including cardiovascular risk profile, symptoms, and treatment goals. The integration of Traverse findings into clinical practice guidelines will likely influence future recommendations from professional organizations, including potential updates to the AUA guidelines on testosterone deficiency. Did you know? The Traverse trial provides definitive cardiovascular safety data for testosterone therapy in men with testosterone deficiency and elevated cardiovascular risk. The study demonstrated non-inferiority for major adverse cardiovascular events, with comparable rates of myocardial infarction, 2.1% versus 2.3%, stroke, 0.9% versus 1.1%, and cardiovascular death, 0.9% versus 1.1%, between testosterone and placebo groups. Alternative therapies preserve fertility while treating testosterone deficiency. HCG, selective estrogen receptor modulators, and aromatase inhibitors stimulate endogenous testosterone production, making them ideal options for younger men with fertility concerns or those with borderline testosterone levels. Traverse excluded patients with recent cardiovascular events within 6 months, limiting direct applicability to this high-risk population. Clinical judgment and shared decision-making are essential when considering testosterone therapy in patients with recent myocardial infarction or stroke. Cardiovascular risk factor optimization remains paramount regardless of testosterone therapy decisions. Continue emphasizing lifestyle modifications, medication compliance, and appropriate cardiovascular monitoring in all patients with testosterone deficiency. For more information or to claim CME, please visit the AUA University at auanet.org/university.